hepatitis B, C, and D deaths over a course of a year, it amounts to over 1 million, which ranks up above malaria, above HIV, and on par with tuberculosis deaths worldwide. So it's an extreme problem, and 75% of the people that have hepatitis B live in the Asia Pacific region. So what do we do with Hep B Free is the name of our organization. We work on hepatitis awareness and advocacy. This means public education, producing pamphlets that talk about the effects, complications, and the reasons that hepatitis B needs to be treated. We work on resource and infrastructure development, and this could be building clinics, refurbishing lab buildings, providing power, clean water, greenhouses even. We establish prevention programs, which are mostly in terms of vaccinations and also in maternal to child transmission prevention. We've introduced treatment in most of the countries that you see on the right. We provide treatment and care guidelines in resource-poor environments. We support equipment procurement. This could be biochemical, hematology analyzers, gene expert machines, endoscopy equipment, ultrasound, FibroScan. We do direct patient care, and we train providers. And then we support the integration of programs into national health systems. And the big challenge here has been providing data management systems that can be used by providers in remote areas, but yet can be integrated into the national care system. And then we establish partnerships between the government, ministries of health, other NGOs, and industry. The places that we work are North Korea, Papua New Guinea, a small country called Kiribati, Fiji, Tonga, Vanuatu, Myanmar, most recently in Madagascar, Solomon Islands, and a small island country called Niue. And we're funded mostly through donations and grants, a lot of self-funding, and just a lot of support from volunteers. So the first country I'm just going to kind of give a taste of some of the unique challenges of places that we work. The first place I'd like to talk about is Papua New Guinea. Since in another week, we'll be going back here. Has a population of about 9 million, the closest country to Australia. And one of the big challenges is that there are over 800 languages spoken there. Most people live in rural settings, and transportation is a real problem getting from point A to point B because of the geography. And we work, our first project and biggest project has been in Oro province, which is on the north side, across from Port Moresby, north side of Papua New Guinea. We also work in Milne Bay, which is the peninsula down here, and in Port Moresby itself. Prevalence of hepatitis B is about 10 to 12% by our longitudinal studies that we've done. So our program got started there initially as a vaccination program, which was quite challenging, but we decided that that wasn't enough, and that starting a treatment program was what we needed to do. So what we have done is we have kind of a unique partnership with the provincial government and with the largest employer in Papua New Guinea, which is called New Britain Palm Oil Company. And the company has supported a lot of our efforts, particularly working with people who live within the confines of their palm oil plantations, which are enormous. They span hundreds of square miles of Papua New Guinea. And they also take care of anyone that lives within the plantations, even if they're not employees. They've supported us with biochemical and hematology analyzers, and we have ongoing online training with the providers. And also, we go in person 2 to 3 times a year. So we have about 200 people on treatment. We've identified many, many more, but adherence, because of the long distances involved, has been very challenging. And one of the other big challenges is that there are so many traditional beliefs about disease. Here's a sign that talks about TB is not caused by sorcery, which is a huge problem there of trying to convince people that these medicines won't harm them and that they're necessary to take over long periods of time. This is a picture of some of our group walking from village to village, and you can see what the terrain is like. And when it rains, you can see one of our workers is covering himself with banana leaves to stay dry. This is one of the villages that we work in the Central Highlands. You can see the mountains in the background, and getting there can be problematic at times. The biggest project that we have had over the years has been in North Korea. And this is a map of North Korea. Where we have white circles here are the cities that we work in. Pyeongchang, which is the kind of the Silicon Valley of North Korea. It's where most of the missile program takes place. Military components are built. Pyongyang is the kind of showcase capital. Saliwan is a rural clinic that was the last one that we established. Haeju is a seaport, and Kaesong is right next to the DMZ. In fact, when you are in clinic, you can see the South Korean flags in the distance. So this is a view from space, and it kind of gives you an idea of the difference in electrification in the countryside and just kind of the development of the country. This is South Korea. You can actually see the outline of the DMZ along here with the lights. This is Seoul. This is China up here, and all this is North Korea at night. This is the capital of Pyongyang that you can see with a little bit of light at night. So we first came to North Korea in 2013, along with an American NGO called Christian Friends of Korea, who had been working there for by now about 30 years. We were working in hepatitis hospitals, and we had a request from the Ministry of Health to not only support the hepatitis B program with training and advice, but also to start antiviral treatment, which at the time seemed just kind of far-fetched because drugs were $800 per month per person at that time. They had no laboratory facilities. In fact, you can see over here, this was the hepatitis lab that they had that just used very, very outdated methods of laboratory identification of treatment, and so just the fact of lack of facilities, lack of laboratory capability, and lack of drugs made it seem impossible. But we persevered, and we were able to get a agreement with Gilead Corporation to provide tenofovir for every patient that we treated for a lifetime, which is quite a commitment from them. So we were able to get drugs free of charge, and our next step was to develop the infrastructure that was necessary to allow this program to go forward. So there's about 12% of The population in North Korea is estimated to have chronic Hep B. Most of it's transmitted vertically from mother to child. As you can see, testing methods were very outdated. There was no access to antivirals. The vaccination program through the Global Alliance for Vaccines, Gavi, provided the 3-dose vaccine, first dose it being at about 1 month, but most of the children did not get the birth dose, which is really critical in preventing transmission of hepatitis B from mother to child. And there were a lot of healthcare workers and other high-risk individuals that weren't vaccinated. In fact, the head of the hepatitis program in North Korea with whom we worked had hepatitis B and was not on treatment. So the partners that we have are the Christian Friends of Korea, that American NGO out of North Carolina, our group, Hepatitis B Free, and Global Care Partners, who are lab developing group. And so what we had to do was we had to start from scratch at each of these locations and just rebuild the infrastructure. That would be lab buildings, provide water, electricity, and lab support. We needed supplies for patient support, just food, providing greenhouses, because there's a kind of endemic low level of malnutrition in North Korea that makes it more difficult to treat hepatitis B. We provided imaging, including ultrasound and even a FibroScan machine, treatment with tenofovir and entecavir, training, and then we had to develop a data management system that did not have access to the internet. And we were able to provide develop a very clever system, I think, that allows us to do that offline. And all of our support, again, comes from donations, whether corporate or personal, and volunteers. So just a few photos. These are our minders that usually come. We always have a couple of government officials that follow us around and make sure we don't get in trouble. These are pictures of people, a lot of Scandinavian doctors, American, Australian, New Zealand doctors work side by side there with this. This kind of gives you an idea of kind of the primitive system that they have there. It's not very mechanized. You see people harvesting rice by hand. These are some of the handbooks that we've developed that are educational material that we give to all our patients. And this is a picture of our refurbished laboratory and clinic in Quezon. These are some of the old and new equipment that we had in the labs. And this is me. You can see what happens at night when the solar power goes out. We basically work under artificial light. And here's a picture in clinic. Again, as it's getting dark. And this is check-in of our patients, who are very, it's actually, the patients are very, very faithful in coming back, and adherence is quite good in this country, unlike many of the other places that we work. This is me back in the corner. Usually, since my Korean is just very, very little, I usually get relegated to doing ultrasounds and FibroScans. This is a picture of a FibroScan machine. For those that may not have seen it, it basically works on a shear wave basis. It's also called transient elastography, and allows you to quickly see the stiffness of the liver and whether a patient has cirrhosis or not. Another country I'd like to talk a little bit about is the island country of Kiribati. It looks like Kiribati, but the way they pronounce it is Kiribati. And it's it's a small island country, but it stretches over a vast amount of Pacific Ocean, about halfway between Australia and Hawaii. And it's consists of three island groups: the Gilbert Islands, the Phoenix Islands, and the Line Islands, which are called the Line Islands because they're right along the international date line. This is the main island of Tarawa. For those of you that might be World War II buffs, there was a big battle that took place there, and one of the hospitals one of the main hospitals is built right at the beach where the Marines landed during World War II. But you can see on the bottom photo here, this is the amount of land that's there. And the highest point on Tarawa is 3 meters in elevation. And so the country is going underwater with climate change. And so that's one of the big challenges, what's going to happen in the next 20, 30 years. So it's a low middle income country with life expectancy of about 68. There's about 120,000 people in the country, and there are 22 inhabited atolls scattered across a width of a country as wide as the United States. It has one of the highest prevalences of hepatitis B in the world, of about 15%. And one of the big problems here is it also has one of the highest co-infection rates with hepatitis D. I won't go into Delta virus much, but it makes it much more problematic to try to treat when you're co-infected with Hep B and D, and the death rates are much higher as well. So a lot of challenges in Kiribati. The internet is very sketchy there. Travel getting there is difficult. There's only 2 flights a week going from Fiji to Kiribati. Getting between islands, particularly the Gilbert Islands and the Line Islands, is very, very difficult. There are very few doctors in Kiribati, and trying to maintain continuity and staff maintenance is very difficult. We mentioned co-infection with Hep B and D. There's a lot of, just like in Papua New Guinea, a lot of traditional beliefs that interfere with adherence. And the data management system as well has been trying to develop a national system that will recognize or be a central database for all the cases has been very difficult. And on the local level, establishing a clinic system that uses computers instead of paper has been very challenging as well. So one of the initiatives that we've tried to do in a country like this is kind of push back at the WHO guidelines. The WHO guidelines call for having liver tests like ALT, AST, also for having viral load with Hep B DNA. And having that kind of infrastructure on some of these remote islands has been is next to impossible. So we've tried to develop and we're publishing our experiences with doing this. It's basically doing point of care testing. If someone is negative, we just go ahead and vaccinate them. This is mostly on the outer islands where there are almost no resources. If someone is positive, if they're females, we just start them on treatment if they're 15 years or older. If they're male, we wait till 30 years. And the reason for doing this is with the newer types of tenofovir, you don't need to check creatinine, the tenofovir alafenamide. And by treating all the females that are positive, when and if they get pregnant, they are automatically covered for prevention of maternal to child transmission. And so that we find that this system, now that we can buy tenofovir alafenamide for $5 or less per month, it's more cost effective to just go ahead and treat without trying to develop new lab facilities that will give the lab results that you need. So we're putting that out to the worldwide community as to a possible treatment in very resource poor areas like this where there's not good transportation. And then we are also, there are similar challenges in other islands that we're working, where we've got programs underway, including Tonga. Fiji actually has a lot of resources, but not a lot of commitment to hepatitis B. Vanuatu and the Solomon Islands, we're getting started on programs. And the small country of Niue, there's only about 2,000 people in it, and there are only about 10 people with hepatitis B. But its kind of significance is the fact that it will be the first country in the world that has hepatitis B eradicated, that would be considered eradicated by the WHO. So that's kind of a significant milestone in the treatment of hepatitis B. In Myanmar, we have a series of programs. Here's a map of Myanmar, and you can see its location between India, China, and Thailand and Laos. We work down here in Yangon with another group called Myanmar Medical Action Myanmar, mostly treating patients with Hep B and C. It's kind of a mix here of hepatitis B and C. It's not, there's almost no hepatitis C in the Pacific Islands, but it's about 50-50 here in Myanmar. We work with the Karen people on the Thai-Burmese border with vaccinations. And then our most recent project is way up north here in Putao, which is right at the base of the Himalayas. So here's our clinic in Yangon with MAM. And this is one of the clinics up in Putao. In Putao, since it's kind of in one of those areas where the three countries, China, India, and Myanmar meet, it's a place where a lot of drugs are trafficked. And we have a cohort of patients that have that use heroin in particular intravenously and have developed hepatitis C and also HIV. So we have a cohort of about 250 people that we treated recently with hepatitis C and HIV, which is a little bit tricky with drug interactions. And after completing the treatment, we retested for evidence of cure, and about 90% of the patients were treated, which is quite an accomplishment because many of the people are migratory and often go from Myanmar, their homes in Putao, to other places in China to work where the wages are higher. So it was very satisfying that we had that kind of rate. The other problem here is that there's open rebellion going in this area. And so access to some of the patients is restricted by the Myanmar government. The most recent place that we're working now is Madagascar. We went with a group from Australia called Australian Doctors for Africa, who have been working in Madagascar for quite some time. We worked in the capital of Antananarivo, and then also in a city on the southwest coast called Toliara. This is the hospital in Antananarivo. the facilities are not that bad, but one of the kind of unique aspects of working in Madagascar is the government provides essentially nothing. All medications have to be paid out of pocket, and population is quite poor. And even vaccinations are not free. Even childhood vaccinations have to be paid for by the parents, which is very short-sighted policy by the government, but that has been the policy for some time, which means that almost no one gets birth dose hepatitis B vaccination because most of the people can't afford it, so the rate of hepatitis B is quite high there. This is a village near Toliara. The terrain is much different in that part of the country. It's also a place where lemurs live, and so we got to visit a lemur park, and there's a cute little lemur there. You can see that malnutrition, this is a mother and her child, and you can see how thin the mom is, which is malnutrition is quite prevalent there, and particularly in Toliara. So how am I doing on time? Do I have a few minutes yet, or?
You still have a couple of minutes left, 5 minutes or so.
Okay, so maybe I'll just show a couple of slides since this is kind of in current events of my trip this summer. I spent June in the Ukraine, and so this is a map of Ukraine. In coming into Ukraine, there are no flights, so you have to go by train, and you usually go through this Polish town, Promiesk, if I pronounced that correctly, and then the train goes through Lviv and then to Kiev, and that's generally the way. You can either go there or you can go down to Odessa here in the southern country. We took the train to Kiev. And basically, the group I worked with worked in areas where the Russians had occupied and have now since been those areas have been reoccupied by the Ukrainians. And so we worked up near Belarus and drove down into central Ukraine and had some clinics here. And then we went to Mykolaiv down south and worked there for a couple of days. And then we worked in around Kherson. And recently, maybe a few months ago, the Russians had blown up a dam here, and a lot of this area was flooded. And the Ukrainian forces had reoccupied this area on the west bank of the Dnieper River. And so this is an area that we went to and worked. So this is Kyiv, a beautiful city, lots of history there. This is one of the main squares. And what's interesting about this picture, you can see how the Ukrainians have just kind of adapted to the war. And at the time that this picture was taken, there was a missile attack going on. And you can just see that people aren't really too worried about the missile attacks. You could see the Russian cruise missiles coming in, and the anti-cruise missile rockets going up to deflect them or destroy them. And people, they'd look up, but it happens a couple times a day. And so they just carry on with their lives. We visited, this is up near Chernobyl, the town of Bucha, where about 116 people were massacred early on in the war. You can see some of the damage to apartment houses, cars that have been destroyed on the road by the Russians. And this is around where we had one of our clinics in a rural area. You see some of the damage that was done due to the fighting there. And one of the other problems that has occurred is that the Russians left behind lots of minefields. And sometimes I would just be kind of walking out outside the clinic, and people would remind me that I was in an area that had not been cleared of mines. So that was a little bit scary at times. This is one of the places that we worked, kind of a de facto ad hoc clinic that we had set up. And so that's just a little bit of a few photos from my trip to Ukraine. Thank you very much for your attention, and we have time for questions. We'd be glad to try to answer them.